Picture this. A patient gets wheeled into the ED after taking a really heavy blow to the head. But they're wide awake. They're totally lucid, chatting with you like everything's perfectly normal. And you start thinking, okay, they're out of the woods. Then, just a few hours later, they suddenly and catastrophically crash. It's literally the terrifying talk and die scenario, the classic warning sign of a hidden bleed expanding inside the skull. Welcome to This Explainer. Today we're mapping out the absolute must-know, high-yield traumatic brain injury facts so you can completely crush the NCLEX. So here's our game plan for today. We'll cover the hidden TBI threat, epidural versus subdural bleeds, spotting the signs, priority nursing interventions, and we'll wrap up by testing yourself NCLEX style. Let's get right into it.
Part 1. The hidden TBI threat. To really master these questions, you've got to understand the timeline of the damage happening inside the skull.
Think of an impact rippling right through the brain. That is your primary injury. It's the direct physical damage to the brain tissue and vessels that happens at the exact split second of impact. Maybe it's a nasty fall, a car crash, you name it. But here's the harsh reality. This primary injury, you can't undo it. The damage is permanently done the very second the trauma hits.
But you see, that initial strike is really just the beginning of the nightmare. Enter the secondary injury. This is the silent, deadly buildup of swelling, bleeding, hypoxia, and spiked intracranial pressure, or ICP, that creeps up over hours or even days. And honestly, this right here is your entire mission as a neurotrauma nurse. You have to prevent this insidious secondary injury, because it's this exact cascade of ischemia and pressure that actually drives disability and death. Keep the oxygen up, keep that blood pressure adequate, and keep the ICP down.
Moving on to Part 2, epidural versus subdural bleeds. Let's break down the two most heavily tested intracranial bleeds you're going to see on the exam. All right, let's stack them up. First up, the epidural hematoma. I want you to think of this as the emergency artery. It's an arterial bleed, usually from that middle meningeal artery, which means it bleeds incredibly fast. On a CT, it looks convex, kind of like a lens. But your absolute biggest NCLEX clue? The lucid interval. The patient gets knocked out, wakes up, seems totally fine, and then rapidly crashes as that high-pressure arterial blood literally squishes the brain. It is a massive surgical emergency. Now, contrast that with the subdural hematoma. Think of this guy as the slow senior. This one is a venous bleed from the bridging veins. Since veins are lower pressure, it bleeds way slower, forming a crescent shape on a scan. You'll almost always see this tested in elderly patients or maybe someone with a history of alcohol use. They might have had a minor bump on the head weeks ago, and they're just now showing a creeping, gradual drop in consciousness.
Part 3. Spotting the signs. You've got to know exactly when your patient is tipping from stable into that deadly secondary injury zone.
Okay, here are your absolute glaring red flags. First, a tanking Glasgow Coma Scale, or GCS, paired with pupillary changes, like a newly dilated pupil. That screams expanding hematoma. Next, keep your eyes peeled for signs of a basilar skull fracture. You might spot raccoon eyes, that dark bruising around both eyes, or battle sign, which is bruising tucked right behind the ear. And finally, CSF rhinorrhea or otorrhea. That's clear fluid leaking straight out of the nose or ear. If you test that clear drip and it's positive for glucose, or you catch it on a gauze pad and it dries into a yellowish ring around a bloody center, yep, the classic halo sign, that means you've got cerebrospinal fluid leaking out.
Which brings us to a massive NCLEX trap. Remember this phrase, Basilar equals no nose tubes. Seriously, drill this into your brain right now. If your patient has raccoon eyes, battle sign, or clear fluid dripping from their nose, you never, ever insert an NG tube or do nasal suctioning. Why? Well, with a fractured skull base, that tube can actually pass straight through the crack and literally into the patient's brain tissue. Yeah, no thanks. Always stick to the oral route.
All right, Part 4. Priority nursing interventions. When the clock is ticking, you don't have time to second guess.
Here are your exact prioritized life-saving actions ranked by our trusty ABCs. Number 1, airway. Remember the golden rule. Less than 8, intubate. If that GCS is 8 or lower, they cannot protect their airway, and hypoxia is the absolute deadliest secondary insult. So, intubate with C-spine control. Number 2, maintain blood pressure. A single drop into hypotension can completely wreck their outcomes. Number 3, manage that rising ICP. Keep the head of the bed elevated to 30 degrees, keep their head perfectly midline to help venous drainage, and push osmotic diuretics like mannitol if the doc orders it. Number 4, get ready for surgery if there's a rapidly expanding bleed. And number 5, basilar fracture care. Like we just said, no nasal tubes, definitely don't pack the leaking nose or ear because that just traps the pressure and invites infection, and get those seizure precautions going.
And finally, Part 5, NCLEX Test Yourself. Let's lock this knowledge down with a couple of high-yield questions.
Question 1. A client with a head injury has clear fluid draining from the nose. Which nursing action is appropriate? A. Pack the nose tightly with gauze. B. Have the client blow the nose forcefully. C. Insert a nasogastric tube. Or D. Test the drainage for glucose and note a halo sign. Do not obstruct the flow. All right, I'm giving you 3 seconds to drop your answer in the comments. 3, 2, 1.
And the correct answer is D. You absolutely want to test that drainage for glucose and check for the halo sign to see if it's CSF. Like we talked about, packing the nose just builds up dangerous pressure, and an NG tube is a massive no-go because of the risk of sliding right through a basilar skull fracture.
Nailed it. Okay, let's hit question 2, taking us right back to our terrifying intro scenario. A client who is alert after a head injury suddenly becomes drowsy with a dilated pupil after a lucid interval. This pattern is most characteristic of A. Epidural hematoma, B. Concussion resolving, C. Migraine, or D. Ischemic stroke. Drop your answer down below. 3, 2, 1.
The answer is A. Epidural hematoma. Remember, that brief lucid interval followed by a sudden, catastrophic crash is the absolute hallmark of the emergency artery. It's a fast-pumping arterial bleed that needs neurosurgery like yesterday.
You guys are doing amazing. Let's bring it all home with one final thought to anchor this. Master TBI by preventing the secondary injury. But chew on this for a second. As that intracranial pressure climbs and the brain literally runs out of real estate inside that hard skull, where exactly does all that pressure go if we don't jump in fast enough? Kind of a scary thought, right? If this explainer helped these concepts finally click for you, make sure you hit subscribe. We're dropping one killer med-surg topic every single day until you absolutely pass the NCLEX. Keep crushing those studies, and I'll catch you in the next explainer.